Thanks, Madam President. And thank you for the very kind words of introduction, and thank you all for coming out. It's truly an honor and privilege to be here with you. I think this is the first time I've been to this meeting. I don't think I've been before, but I have close ties with social work, served on a number of social work doctoral committees when I was a faculty at the University of Michigan, and have many colleagues there, and a daughter who did a master's in social work at the University of Michigan. So it's really an honor and privilege to be here with you. What I want to do today is to give you, in the brief time I have, since it's a topic we could talk about at length, briefly the challenge of inequities in health, but to spend more time thinking about the evidence that we have of the kinds of interventions we can implement to address these inequities in health. So I'm going to just jump right into my talk, since I hope that we'll have a little time at the end for questions. There are, in fact, large inequities in health by socioeconomic status, income, education, occupational status, and so on. One example of that is looking at national data for the United States from the Panel Study of Income Dynamics. This is looking at the relative risk of all-cause mortality for low-income Americans, defined as incomes less than $25,000, to high-income Americans. And what you can see is a graded association. The higher the household income, the lower is the risk of overall death. If the socioeconomic status is such a powerful predictor of variations in health, it's likely that race and ethnicity would also be powerful predictors, because there are large racial differences in socioeconomic status in the United States. And I'll give you 2 bullet points on that. Here is national data for the United States, median household income in 2015 by race and ethnicity. And I've just translated the data in a way you can't possibly miss the point. So I'm standardizing on the household income of white households, and for every dollar of household income white households receive, Asian households receive $1.23. Asians are heavily made up of immigrants. They come to the United States with very high levels of education, and Asian households have more persons contributing to household income than whites. So if we had a per capita measure of income, whites would have the highest. But if you look at the historically disadvantaged groups, for every dollar of household income white households have, Hispanic households have 72 cents, Native American households 62 cents, and black households have 59 cents. This is 2015 data. The 59 cents figure for blacks is identical to the black-white gap in income in 1978. I did not misspeak, you heard me correct. In 1978, the peak years of the narrowing of the black-white gap as a result of the anti-poverty policies of the 1960s and the civil rights policies of the 1960s and 70s, the gap had been reduced to 59 cents, and in 2015, it is still at 59 cents. Has it been consistent at 59 cents throughout the years? No, it fell throughout the decade of the 80s, fell from the 59 cents figure, and it wasn't until 1994 it got back up to where it had been in 1978, and it's been a penny up and down since then. Most of my students think we've made much more progress in the United States than we actually have. And data on racial differences in income dramatically understate the racial differences in economic resources, because income only captures one small component, the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on assets and wealth. And if you look at the Census Bureau report from 2014 on racial differences in wealth, for every dollar of wealth white households have, black households have 6 pennies, and Latino households have 7 pennies. So we really have striking inequities in the United States. And across the globe, race matters profoundly for health. I'm going to run through very quickly some data just showing you the pattern that it doesn't matter where you look, race matters profoundly for health. infant mortality in the United States in 2015, you see the elevated risk for African Americans and Native Americans. If you look at data for England and Wales, you can see blacks from the Caribbean, blacks from Africa, Pakistani have markedly elevated risk of infant mortality. If we look at South Africa, we see the patterns of infant mortality mirrors the apartheid historically of South African society, with whites doing the best, blacks doing the worst, and colors and Indians in between. If we look at data from Latin America, looking at the African-descended population in Latin America, you can see in Costa Rica, in Panama, Uruguay, Venezuela, Brazil, Ecuador, Colombia, that Afro-descended populations have higher rates of infant mortality. If we look at the indigenous population across Latin America, you can see in Costa Rica, Uruguay, Mexico, Colombia, Brazil, Venezuela, Peru, Ecuador, Panama, Guatemala, Bolivia, that the indigenous population has, in fact, worse health. So everywhere you look, the pattern is consistent, and we need to understand what are the systematic factors that are producing these predictable inequities across populations. I also want to highlight that there's some ominous storm clouds that doesn't portend well as we look to the future. I'll just touch on them briefly. One is there's been a lot of media coverage recently on pregnancy-related deaths, maternal deaths among African Americans, and you can see here is data from 2011 to 2015, and you can see the elevated risk of pregnancy-related deaths for African Americans and Native Americans in the United States. Childhood obesity is another problem. The work of one of my colleagues, Steve Gortmaker, shows at age 2, Black and Latinos have higher rates of obesity than whites. And if we look at all Americans aged 2 to 15, 57% of all Americans aged 2 to 15 will be obese, not overweight, but obese by age 35. For African Americans and Latinos, 67% will be obese by age 35. So this has significant implications for the health of the population in the future. Another storm cloud is the high levels of mental health problems. There was a recent study of the rates of suicide among elementary school children in the last 20 years. And nationally, the rates have been stable. But that stable rate nationally masks the fact that the rates have been stable for Latinos and for Asians. They have declined markedly for whites, and they have dramatically increased, have doubled for African Americans. I don't know that I knew what suicide was when I was an elementary school student, but here is data showing for black boys in America, the rate of suicide has doubled from 1993 to 2012. What does it mean to be growing up black in this society today? It raises profound questions, but it's a challenge, one indicator of mental health challenges that we face. When my career started, most people thought that the racial differences in health was simply a function of racial differences in socioeconomic status. And if we looked at individuals at the same level of socioeconomic status, race wouldn't matter. We now know that is profoundly not true in the United States, in South Africa, in the UK, in Australia, in New Zealand. In all of these countries, there is a residual effect of race, even after you've taken socioeconomic status into account. I'll give you one image of this, national data for the United States on infant mortality and by mother's education. And you can see as mother's education increases, infant mortality rates decline. But you still see the best off African American women, black women with a college degree or more education, have higher levels of infant mortality than white women who are high school dropouts or Hispanic women who have not finished high school. So you see the towering excess risk linked to race. So there's something about socioeconomic status that matters for your health regardless of your race. But there's something else about race that matters profoundly after you've taken socioeconomic status into account. And so for the last 20, 25 years, I and many others in the United States and increasingly around the globe are looking at racism and the ways in which racism profoundly affect health. And its most powerful effects are through its institutional or structural mechanisms that shape access to opportunity in contemporary society. I have written about the role of residential segregation and the power that it plays in shaping outcomes. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa in the early 20th century looked across the Atlantic and saw residential segregation and how well it was working in the US, and they said, brilliant, we will implement that in our country. Importantly, Sell argues that segregation by race was one of the single most successful domestic policies of the 20th century in the United States. It's beneath the radar screen, but it's having profound effects on shaping access to opportunity. You say, what does segregation have to do with health? Well, where you live determines where you go to school and the quality of education you receive. It determines access to job opportunities, qualities of neighborhood environments and housing, whether you have access to fresh fruits and safe places to exercise. It determines exposure to physical, toxic, chemical substances. It determines access to medical care and the quality of city services. So virtually all of the factors that determine health are in fact powerfully patterned by place. Two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, studying the 171 largest cities in the United States, said there's not even one city in America where whites live under equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. That is segregation working to produce the results it was designed to produce. And another Harvard colleague, David Cutler and colleagues, looking at a national sample of blacks and whites making it in the labor force, using fancy econometric models to, in fact, isolate the impact of segregation. This shows if we could eliminate segregation by residential segregation by race in America, we would completely erase black-white differences in income and in education and in unemployment, and reduce black-white differences in single motherhoods by 2/3. All of those opportunities are driven by place. And Raj Chetty has shown that the intergenerational transmission of inequality is completely driven by the neighborhood in which you live, and that 99% of African Americans do not live in neighborhoods that would give them the same access to economic opportunity as whites do in the United States. So we need to begin by recognizing that these large racial ethnic differences that we see didn't just happen. They're not random events. They're not acts of God. They reflect the successful implementation of social policy. And we need to consider what are the social policies that we can now implement to change the course of access to opportunity in this society. I've talked about this racism. There are multiple mechanisms. I've talked about one, institutional mechanisms. Racism also plays out at the interpersonal level in terms of interpersonal exposure to discrimination. And Martin Luther King suggested that discrimination was a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as a truth in the society dominating them. It's clearly a hypothesis that could be tested. And I and many other researchers have tested this hypothesis. And we have found that, in fact, interpersonal exposure to discrimination, even little day-to-day events like that are captured in my everyday discrimination scale, being treated with less courtesy or respect, receiving poorer service than others in restaurants or stores, people acting as if you're not smart, those little events powerfully predict a broad range of outcomes. And this slide just illustrates some of the outcomes that have been shown to be linked to discrimination. So discrimination is a powerful predictor, interpersonal discrimination. And we now have studies from Australia, from New Zealand, from South Africa, from the United Kingdom, and from the United States that find when you look at racial differences in health and you statistically adjust for income and education, you find an added reduction in the racial gap in health when you add a measure of interpersonal discrimination. So we now know that interpersonal discrimination is, in fact, a driver of these inequities in health. What can we do? That's what my talk is about. Strategy number one, we need to create opportunities, communities of opportunity, to minimize, neutralize, and dismantle the systems of racism that create inequities in health. What do communities of opportunity look like? They are places that invest in early childhood. We have high-quality evidence from studies such as the Perry Preschool study done in Ypsilanti, Michigan, that documented that an early childhood intervention has dramatic, profound effects. 40 years later, those infants from a public housing project who received an early childhood intervention had higher levels of education, higher levels of income, higher levels of employment, higher levels of savings, home ownership, marriage, less involvement with the criminal justice system over their lifetime, less involvement with the social service system over the lifetime, and for every dollar invested, there's a $17 return to society. So it works, has dramatic effects, and it literally saves society money. In fact, as James Heckman has a recent report published last year that have now followed the children of those who were in the Perry Preschool project. And he's finding that the children of those who were in the intervention group have fewer school suspensions, lower levels of crime, higher levels of education and employment. The effects are stronger for males than for females. The effects were due to a better childhood home environment. The effects exist even though the intervention families live in similar environments than the control families, and the positive effects are not only there for the siblings, but for also the siblings who participated in the program. So again, investing in early childhood has ripple effects, and other family members has ripple effects intergenerationally. What we also need to do, if we will have these communities of opportunity, is reduce childhood poverty. This is data from UNICEF showing how America ranked 34th in the world on childhood poverty. Many countries, much inferior to us in economic resources, do a better job of taking care of the children than we do. And childhood poverty in the United States is patterned by race ethnicity. Here are the childhood poverty rates in 2016. 1 in 3 blacks and Native Americans are growing up in poverty, 1 in 4 Latinos, and 11% of Asian Americans and whites. If we think numerically, the largest group of poor children are Latinos, the second largest group are whites, and the third largest group are African Americans. So there's a lot that we can do in terms of addressing childhood poverty. Here is a chart from the UNICEF report, and it has a profound message for us. What it shows is the childhood poverty rates in multiple societies before taxes and transfers. Before taxes and transfers is a childhood poverty rate produced by the economic system. So let's look at Ireland. The economic system in Ireland produces a child poverty rate of 42% of the kids are poor. However, once the Irish implement their policies, taxes and transfers reflect the policy preferences of society, the child poverty rate is reduced from 42% to 8%. You could see in New Zealand, it's reduced from 30% to 13%. In Canada, from 25% to 13%. In the US, the economy produces a child poverty rate of 24%. And after our policy preferences, we indicate what we value in this country, it is reduced by 1 percentage point. So there's a lot that we can learn from other societies in terms of reducing child poverty as a strategy to invest in opportunities for the future. What else do we need to do to develop and establish and maintain communities of opportunity? We need to keep the social safety net in place as a resilience resource. We talk a lot about resilience, but we often think of resilience only at the psychological level. Resilience is also a profound factor at the social level and the political level and the policy level. And keeping the social safety net in place is a resilience resource. And we don't have to guess what happens when we tinker with it. We just can take a walk down memory lane and look what happened early in the Reagan administration, the Omnibus Reconciliation Act of 1981 that savaged the social system in the United States. 500,000 people lost welfare. 1 million persons were dropped from food stamps. 600,000 lost Medicaid. In some states, only 20% of the poor were covered. In some cities, there was a 21% decrease in Medicaid eligibility. What was the impact of these cuts? There was an increase nationally in low birth weight. There was a decline in infant mortality that was evident nationally. Child blood lead levels increased for the first time in many years. Over 250 community health centers were closed. 1 million children lost reduced-price school meals. There was an increase in infant mortality in poor populations in 20 states. There was an increase in women not receiving prenatal care and an 143% increase in anemia in pregnant women. There were new cases of measles increased for the first time in many years. There were studies in Boston, Chicago, and Minneapolis that show more children showing up in the ER with preventable childhood conditions. We are living in a time when there are proposals in this town to reduce and weaken the safety net, and we cannot be silent. What else can communities of opportunity do? They need to enhance income and employment opportunities for youth and adults. I don't have time to review the evidence, but there's a lot of evidence that shows, as a result of the civil rights policies that provided additional income to African American households between 1968 and 1978, is the period in the last 60 years when we have had the largest narrowing of the black-white gap in health. Improvements in income led to improvements in health. We have studies of the earned income tax credit, studies of the implementation of the Social Security and living adjustments to Social Security over time that leads to improvements in health of the elderly. We have studies from around the world of conditional cash transfer programs that shows additional income is linked to improved health. We have studies like the Great Smoky Mountain study that showed additional income to Native American households leads to improvements in health and the elimination of some racial disparities in health. I just want to give you an example of one concrete study. This is a study that looked at the impact of the minimum wage and increases in the minimum wage on infant mortality. And these researchers found that a $1 increase in the minimum wage above the federal minimum was associated with a 1 to 2% decrease in low birth weight and a 4% decrease in postneonatal mortality. The scholars concluded that if all states in 2014 increased their minimum wage by $1, there would have been 2,790 fewer low birth weight births and 518 fewer postneonatal deaths for the year. So again, improving economic opportunities for poor households have dramatic effects on health. What else can we do? What do communities of opportunity look like? We need to improve neighborhood and housing conditions as well that have ripple effects on health. There are multiple examples of evidence along these lines. The Move Into Opportunity Project is one. The Yonkers Housing Intervention is another. There was a citywide deconcentration of public housing. Public housing residents were randomly selected to move to better housing. Those who moved 2 years later had better overall health, less substance abuse, less neighborhood disorder, less violence than those who stayed. They enjoyed better city services, better access to medical care. They had high rates of employment and lower levels of welfare use. We have from the Move Into Opportunity Project that just changing the neighborhood leads to reductions in obesity 10 to 12 years later, lower risk of diabetes 10 to 12 years later, just by changing the neighborhood. Now, I like the Move Into Opportunity study and the Yonkers Housing Intervention. They give us high-quality scientific evidence that just changing the neighborhood environment, no health intervention, leads to health improvements. I don't think they are viable, practical policy solution. They've given us good evidence. People should not have to move out of their neighborhood to live in a better neighborhood. We need a Marshall Plan for disadvantaged communities in the United States where we can improve the quality of living and housing environments. Can this be done? Yes, they have done it. It's been done by the Purpose-Built Communities organization that was born in Atlanta and is now building these communities across the United States. And one of the distinctive things that they do is they seek to address all of the challenges faced by disadvantaged communities simultaneously. Let me give you an example of the first project they implemented. Eastlake Meadows, 1995, a public housing project of African Americans where 90% of the families who lived there were a victim of a felony every year. It was public housing. Many of the units were completely dilapidated. Only 13% of adults were employed, 59% were on welfare. This elementary school linked to this public housing project was one of the lowest performing in the entire state of Georgia. Only 5% of fifth graders met state math standards. I visited the villages of Eastlake 2 years ago, a completely transformed area where there's been a 90% reduction in violent crime, where there's high quality housing with 50% for persons who still qualify for public housing, 50% at market rate, where every able-bodied person is employed, and where the school is now one of the, every year annually, one of the top 5 performing in the entire state of Georgia, the elementary school, even though 60% of the students in the school still qualify for reduced price lunches. So it shows us that it can be done if we make a commitment to do it, and Purpose-Built Communities is providing free technical assistance to any community in the United States who wants to replicate their model. What else can we do? Remember, I'm talking about all the evidence we have of things that can work. Well, we need to build more health into the delivery of healthcare if we will be successful in addressing inequities. One of the things we need to do is to ensure access to care for all. I want to give you an example of an experiment for the nation that was done in the state of Delaware. The state of Delaware decided to address the challenge of colorectal cancer in their state. And so they implemented a program which provided, at no cost, colorectal cancer screening to anyone in the state initially whose income was less than 250% of the federal poverty level. Then they added colorectal cancer treatment to the program, and special outreach efforts to disadvantaged communities and minority communities to ensure that individuals were aware of the program and knew how to navigate the healthcare system to benefit from it. What happened? Between 2001, when the program was implemented, and 2009, we had an elimination of screening disparities for colorectal cancer. And the elimination went in exactly the direction we'd want. We had dramatic increases in the colorectal cancer screening rate for whites, and even larger increases in this colorectal cancer screening rate for African Americans, so the gap was eliminated. We also saw the same with incidence of colorectal cancer. And again, marked declines in the colorectal cancer incidence for whites, even larger declines for African Americans, and an elimination of the incidence of new cases of colorectal cancer in the state of Delaware. And we also saw for colorectal cancer mortality, marked declines for blacks, marked decline for whites, and a near elimination of the mortality difference. It shows it can be done. This is done in one state. Why isn't it being done in 50 states? Not every health problem can be solved with a medical intervention, but for those that can, this shows that equal access to all and efforts to ensure that everyone can be engaged can, in fact, have dramatic effects. What else do we need to do to build more health into the delivery of health care? We need to eliminate inequities in the receipt of high-quality care. It was mentioned in the introduction back in 2002. I served on a National Academy of Medicine report that produced the Unequal Treatment Report that documented across virtually every therapeutic intervention in the United States, from the most simple to the most complicated, blacks and other minorities receive poorer quality care and less intensive care than whites. That was in 2002. We have hundreds of studies since 2002 documenting this pattern still persists. We believe that unconscious bias or implicit bias is a factor driving this, and we now have high-quality scientific evidence that we can reduce implicit bias. I'll give you one example. It comes from a randomized, double-blind, parallel group, placebo-controlled study in the United Kingdom that showed a single dose of a beta blocker eliminates implicit bias for the next 2 hours. So implicit bias can be eliminated by a pharmacologic intervention. This is actually a very important point. We are living in a country where both the president and the vice president have said that implicit bias is fake news. The fact that implicit bias can be eliminated by a pharmacologic intervention clearly indicates there's something fundamental in terms of how our brains are functioning that we can alter brain functioning by a pharmacologic intervention. Now, I am not suggesting that we should medicate all health professionals for the rest of their lives. There is evidence of multiple strategies that can be implemented that reduce implicit bias. Strategies like stereotype replacement, like counter-stereotype imaging, like individuation. We all interpret the complex cognitive information we face every day through social categorization. So for example, when we meet someone, all of us do it. It's normal, it's natural. We focus on in 1/3 of the time it takes to blink our eyes, we focus on that person's sex, race, and age. And depending on what's deeply embedded in our subconscious about the social groups to which that person belongs, we will treat them differently. I like to tell my students that I think of myself as a prejudiced person. I think of myself as a prejudiced person because I like to think of myself as a normal human being. And if you are a normal human being, you're probably prejudiced. I didn't say you're racially prejudiced. Race is only one basis of it. But this is how every society, every culture, every community has in-groups and out-groups. Groups that are viewed positively and groups that are viewed negatively. And when we meet based on where we were raised and what is deeply embedded in our subconscious, and we put them into that social category, and if the social category has negative attributes, the research shows we will treat that person differently without our conscious awareness, without any intention on our part. It's a normal human process. So you may not be racially prejudiced, but what are your deeply embedded stereotypes about fat people, about gay people, about old people, about women? The social groups may vary, but these are profoundly normal processes for us all. The good news is there's the Devine Solution. Professor Patricia Devine at the University of Wisconsin has shown that you can put all of these prejudice-reducing strategies into a single program, enable people to become aware, help non-blacks to be motivated to increase their awareness of bias, increase their concerns of bias, implement all of these strategies, and these strategies were effective in substantially reducing both explicit and implicit bias, and the reductions remain evident 3 months later. So there's strategies that can be implemented, we can do it, but it has to begin by our recognition, this could be me. The persons who say, I don't see color, I don't see race, I treat everyone the same, is the person exactly set up to do it. There's increasing calls in academic circles that we need to move beyond cultural competence and begin addressing structural competence. Because those implicit bias that shape how we function individually have also shaped how our institutions are structured, have also shaped the policies we have implemented. And we need to think more broadly about these inequities and go beyond the individual level and think of how we can change our institutions as well. What else do we need to do in building more health into medical care? We need to provide care that addresses the social context. The World Health Organization asked the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? And so we need to be asking a whole new set of questions of how can we identify in the healthcare context not only the medical needs that people present with, but their non-medical needs. How can we connect patients with local services and resources? How can we blend social work more centrally with medical care? How can we collaborate with other sectors to address the challenges that individuals face? And there are multiple programs that are doing that. I'll just give one example. Is a program born at the Boston Medical Center more than 30 years ago. At the Boston Medical Center, the Safety Net hospital in the greater Boston area, in the pediatrics unit, a primary care provider can refer a patient to a number of specialists. One of the specialists the primary care provider can refer a patient to is an attorney. The hospital has on-site lawyers to solve problems in the lives of their patients. So imagine a mother brings a child with asthma, and the asthma is secondary to the housing conditions that they live in. All the asthma medications in the world will not help that child to breathe symptom-free if the child goes right back to live in the same conditions that triggered the problem in the first place. And the mother who has complained to the landlord and has had no results, it does make a difference when a lawyer calls and says, if you don't fix the problem, that is in violation of the housing code of the state, we will sue you for the problem. The Medical Legal Partnership is in more than 200 hospitals across the United States, but it is one example of taking a broader context of a patient's lives and trying to address all of the challenges they face. One of the things we need to do is also to build more health into healthcare, is to diversify the workforce to meet the needs of all patients. And I'm going to draw an example from medical care, but this applies to all professions. It's not just physicians. A report from the American Association of Medical Colleges in 2015 reported that in 2014, there were 27 fewer African American males in the first year of medical school than there had been in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2012, 3.8% of all practicing physicians were black, 5.2% were Hispanic. Most people think we have made more progress than we have. There's a lot of work to be done, and as we face a more diverse population in the future, we need to be investing in our young people today. I like to tell people that in 2016, the majority of persons on Social Security will be white in 2016. There'll be 2 persons paying into the Social Security system for every beneficiary. One of those 2 will be black or Latino. Those kids are in kindergarten today. If we want a viable Social Security system for ourselves when we retire, we need to be taking the policy actions to ensure that those black and Latino kids, the Native American and other kids in elementary school and kindergarten today are getting the best quality education so they can be productive citizens, earning good income, paying into the system so there's a system when we retire. It's in our own interest to do it. One of the things we need to learn, though, as we look at affirmative action policies over the time and the extent to which they have not been as successful as we would have liked, is to recognize that it's not enough to open the gates of opportunity, but we need to ensure that everyone is enabled to walk through the gates. And that's a profound point we need to grapple with. As a society, we need to understand the words of Plato that there's nothing so unfair as the equal treatment of unequal people. And if we are living in a society with mass inequities, we can't treat everyone the same when they are not starting at the same place. What else do we need to do? We need to raise awareness levels of the level of racial inequities in health and in socioeconomic status, and we need to build political will to address them. And you say, what is holding us back? I'm showing you all kinds of evidence, and there's a lot more. We know what would work, and we know it would save us money. What are the barriers? What's the elephant in the room? Why we aren't making more progress in addressing these issues? Well, first of all, national data reveal that many Americans, see inequities in health as the fault of minorities themselves. Many are indifferent, and I would argue some are even delusional. So here is a 2018 national survey that asks people, the national study of American population, that if blacks would do as well as whites if they only tried harder. Racial inequities in all domains of society could be eliminated if blacks only tried harder. 42% of Americans believe that just trying harder by blacks would solve it. 72% of Republicans compared to 23% of Democrats. Blacks would do as well just by trying harder. 45% of all whites, 43% of Latinos, 24% of blacks. If we look within the white population, 52% of white males compared to 39% of white females, 51% of whites with less than a college education compared to 33% of whites with a college education. So we face 3 communication challenges. We need to raise awareness levels of the problem of inequities. We need to build a science base that will guide us in developing political will of what we can do to build a political will. And 3, we need to build empathy. I'm going to elaborate quickly on these 3 points, and then I'll stop. We need to build political support to address inequities in health. Research finds that most Americans are not aware that inequities exist in the first place. Most American adults do not know that there are black-white differences in infant mortality or life expectancy. Not only that, we have research that tells us that whites are less likely to support an initiative if it's going to help blacks than if it's going to help poor people. So here's an example of a national study done, and people were asked, would you support the government giving business and industry special breaks for locating in poor and high unemployment areas? And 70% of whites said they would support that. But the other half of the sample was asked, would you support the government giving industry and business and industry special breaks to support in largely black areas? If the queue was black, only 43% of whites supported it. Whereas among blacks, we don't get much difference whether it's to help the poor or it is to help the racial minorities. So you can see the lack of political support. What drives this? It's not a mystery. Back in 1899, W.E.B. Du Bois wrote a book called The Philadelphia Negro. There's a chapter on Negro health that lays out some of the kinds of statistics I've shared with you today, 1899. And as he came to the end of the chapter on Negro health, he penned these words: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And Du Bois continued, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. So he's saying the fundamental problem is what he called the peculiar indifference of the American public. And scholars today study it and they call it the empathy gap. We don't care as much for something that happens to persons of another group as opposed to our own group. That pattern has been documented around the world, not just by self-reports of individuals, but here's a review paper that looked at brain imaging data, looking at the suffering, when we look at the suffering of someone from our group compared to the suffering of someone from a different group. What is even more disturbing is there's research that shows that this lack of empathy across racial groups developed early in life. Here is a study done with 5-year-olds, 7-year-olds, and 10-year-old, mainly white kids in the US. And the kids see someone sticking a person in their arm with a needle. And they are asked to report how much pain is the person experiencing. At age 5, there is no difference whether the person is black or white. The kids see no difference in pain. By age 7, there's a tendency to see the white person experiencing more pain than the black person. And by age 10, it is pronounced. So the racial gap in empathy develops early in life. What can reduce it? The review paper said that individuation, we talked about that around implicit bias, so some of the same factors operate. When individuals are on the same team with members of a racial in-group, it tends to reduce it. And persons who have had greater interracial interaction in their early socialization also tend to be less likely to manifest the empathy gap, which is the brilliance of integration in schools. And today in America, the tragedy is schools are as segregated as they were in 1954. So we need to think of what we do as a society to dismantle the cultural racism that is deeply embedded in our culture. And we can think of how the media can be engaged to do this. There have been papers published documenting the success of the media in reducing discrimination and prejudice against LGBT populations. The problem is not solved, but we've made a lot of progress. It hasn't happened. There have been studies, there have been interventions implemented in the media. There's also evidence of some innovative interventions that can be implemented at the interpersonal level. And I give you this example of a study that was done, randomized controlled trial, a 10-minute non-confrontational conversation was done. They used 56 canvassers who went door to door. The focus was on transgender discrimination. In the script, the canvasser tried to get the person they were talking to do most of the talking. Their goal was to help that person remember a time in their life when they had been treated negatively so that they could empathize with the transgender individual and appreciate the challenges they faced. And what this study found was that the intervention led to substantial reductions in prejudice against transgender individuals. It led to increased support for a policy, a law that would protect transgender individuals from discrimination. Those changes were evident whether the person being canvassed was Democrat or Republican. Those changes were evident whether the person leading the conversation was a transgender person or non-transgender canvasser. And the effects would not only lead to prejudice reduction then and the willingness of people to vote for a transgender initiative on the ballot, but 3 months later, the effects were still evident. The interesting thing is the group that developed this 10-minute conversation that could be used as an intervention tested more than 13,000 conversations before they identified this one that would work so well. It highlights the kind of research that we need to do to find the right words, the right language, the right framing that can be effective in shaping policy and reducing prejudice. I also want to say one of the things we need to do is to enhance individual and community capacity. We can't do these interventions from above without engaging persons at the local level and various community institutions and organizations. They need to be empowered. They need to be at a table. Their voice needs to be heard. Their knowledge and wisdom needs to be incorporated in the interventions that we implement. Martin Luther King said that true compassion is more than flinging a coin to a beggar, but it understands that an edifice which produces beggars needs restructuring. We live in a society with many edifices that are producing beggars, and they need to be restructured, and that begins by us all voting and encouraging people to get out to vote in this upcoming election. I leave with you the words of Robert Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. There are mighty walls of oppression and resistance, but my hope is that each of us would today recommit our lives to being ripples of hope, and that we can work together to sweep down those mighty walls of oppression and resistance. Thank you. Thank you very much. There are 2 microphones up front. I think we have 5 minutes for questions. If you could quickly identify yourself and ask a brief question, and I'll try to give a brief answer. So we could get a few people. Yes, go ahead.
Hi, my name is Robert Hawkins. I'm from New York University, and I want to say thank you for this. And you don't know this, but you are a huge presence in all of my classes.
Thank you.
And you just reminded me why that is. My question, I've seen you speak other places, and a lot of your work centers around health and health disparities, et cetera. I've been reading your recent work on sleep. I always try to frame what I've learned from you in the context of social work. And in social work, I have a policy background, so a lot of this resonates with me. But a lot of what I see in social work, it's centered around understanding that racism exists, understanding the effects of it, but really focused on helping people manage their presence within racism. So if I'm a person of color, I'm experiencing racism, a social worker might, not all, might say, well, this might be how you approach being in that system, living in that system, rather than understanding and advocating for changing that system. And I just wanted to hear some of your thoughts about that.
Okay, I'll be brief, and that was not a good model of how long to speak, so the other speakers quickly don't follow it, but thank you for the question and the compliment. I would say, I think it was clear from my talk that we need systemic change. At the same time, I don't think it's either or. We need to do both. There are people who are suffering now. We need to help them. We need to help them cope. We need to help them make the most of the situation within which they are, but we can't stop there. We need to go further and further upstream and think of how we can dismantle the systems in the first place. I think you're next, and then I'll come to your mic.
Thank you. I'm a doctoral student at UT Austin. My name is Liana Petruzzi. I was hoping that you could just talk a little bit about Medicare for All, or changing the healthcare system that we have in terms of expanding access in a health equity way. Okay.
In the limited time that we have, I would say my point is one of the things we need to do is ensure access for all, that in fact it is a disgrace, honestly, that we are the only industrialized country in the world that don't guarantee all of our citizens, all of our residents, access to medical care. So we can talk about how we best do that, and how we best do that in the context of the US. We spend more money on medical care than any other country. According to the World Bank, half of the money spent on medical care in the world annually is spent in the US. We less than 5% of the world's population consume 1/2 of its medical resources and have large inequities. There's a lot we can do. Okay, quickly.
Thank you for being here. My name is Kiana Brown. I'm an assistant professor at the Rutgers University School of Social Work. My question is, how do we move from knowing what needs to be done to doing it? Other than enacting policy change, and effective policies are hard-won and slow to come by. How do we move into action?
I agree with you, we have a problem. I specifically outlined 3 communication strategies. People are not motivated to address a problem if they don't know it exists. One of a national study done about 8 years ago found that 51% of African Americans did not know that there were black-white differences in life expectancy and infant mortality. And the numbers for Latinos and whites were much, much higher. So most Americans don't even know that there are inequities in health. A recent study showed that if you look at inequities in socioeconomic status, highly educated Americans were more likely than lower SES Americans to overestimate the racial progress that has been made, and to think there is no problem, and especially if they believe in the beliefs of a just world, because it justifies their positions in society, that they're doing fine and that everybody else could be doing as fine as they are. So we have major communication initiatives. I like to say that those of us who want to see change in society, want to see change in health, and in inequities in health, we need to do a lot more work with communications experts and a lot more work with political scientists. There is work that needs to be done in raising awareness levels, but I also said we need to build a political will, and one step to doing that is to find ways to tell the story in a way that emotionally connects with individuals so that we can establish the empathy to move forward. The last point I would say to all of you, I know many of you are in the academic field, do something that I have learned to do, and I learned it from a sociologist who worked at NSF, where he ran the social and behavioral programs, and he said people keep giving him ideas of things to say at his next congressional brief, and he says, I have all the evidence I need. What he needs is to change the persons who are sitting around the table making decisions. And he says, I want you, talking to a group of sociologists, I want you to go back to your classrooms and tell some of your brightest students to run for political office. We need to do the same. Last comment or question today.
Yes, hi, Philippe Copeland, Boston University. Given everything that you said today, would you say that reparations is a public health issue?
In 2004, I published a paper entitled Reparations, a Viable Option to Address Racial Inequities in Health. It's not been, my work is highly cited, but that paper itself is not. I'm honestly not sure that reparations is a viable political option in the current environment, but I think conceptually, if we talked about segregation, which is a mechanism of racism that has produced these inequities, starting back with slavery, there's this golden cord that has run, it makes perfect sense. And one of the things I suggested about the reparations initiative I proposed, which not everyone would agree with, that I would target it at disadvantaged communities regardless of race. So poor communities in Appalachia would benefit from the reparations initiative that I thought about. Let's change the opportunity structure at the level of the community and give everyone a chance to succeed. Will that happen in this environment? I don't know. But there's a logical case that can be made for that. Again, thank you so much for coming out and for your support.